Thanks very much for the invitation, and I'd just like to congratulate Max on successfully establishing an MDM. I think as oncologists we just regard it as part of what we do, and it's really wonderful to see it entering the world of ocular oncology, because I think it's a big need. So I'm going to try to skip over quite a lot, and I'll try not to be too quick, but also not go over time. So radiation has been used for an extremely long time to treat eye tumours, really as long, it's interrelated with surgery. And the ophthalmologist in the audience will know that Henry Stallard is sort of the big name associated with the development of plaque brachytherapy through the 1930s and 40s, although he got a bit sidetracked doing war trauma in eyes. I found some interesting papers to read in that regard. And he started off using radium and radon, and then obviously that's quite toxic element that's very hard to use, so a lot of work was done with cobalt, and then more recent times it's been iodine, and even more recently ruthenium. But the work that he did a very long time ago, it was very empirical, as a lot of radiation oncology was in the first half of the 20th century. He just sort of gave treatment, had a look at what happened when you gave a certain dose, and tried to work out what was the right thing to do. And so nobody's ever really worked out what's the correct dose for choroidal melanoma. It's just doses that have evolved over time. And so these days, in Australia, a lot of ruthenium plaque is used. This emits a thing called a beta particle, which is a nice tool to use in the eye because it doesn't have a very deep depth dose, as we call it. Its energy is low. It's a nice, less toxic treatment, but a lot of departments still have iodine, and a lot of publications about brachytherapy are about iodine. And typically the dose is about 80 to 85 gray of the tumour apex. And the planning systems are still fairly simple, to be honest. You can see here from this picture that Stallard published in the 1960s. This is what it was modelled for the depth doses. You went from the surface, where you've got something like 40,000 rad there, got to get my right units, coming down to 4,000 rad. You can see the sort of range of dose there very quickly. And these sort of simple ideas about how the dose is distributed essentially underpin what's done currently, although there is a non-FDA approved 3D CT-based planning system which is of interest in the future. And just for those who don't know what brachytherapy is, this is a little radioactive bit of metal. They get bombarded with electrons to make them more radioactive. You place them in some sort of arrangement, and then this little thing called the plaque is attached to the eye. Thanks to Willie Campbell for these pictures. Just for those who don't know, so a surgical procedure, the surgeon needs to remove the oculomotor muscles that are in the way, and then they transilluminate the globe to try to define where the tumour is. In some form it's tattooed or mark out where they think the tumour is, and then they apply that plaque. The muscles are put back on, the patient goes home, and they're walking around with their little plaque in for a while, and it usually takes about 3 or 5 days to deliver the dose, and then you take the plaque off. People will also have heard of proton beam therapy, which is also what I'd call quite an old practice. Boston's been using it since at least the 1970s. Proton therapy was a little bit like we have with synchrotron in Melbourne now, that originally in the 1960s some research facilities were built which were very much physics laboratories, and they tacked a little bit of medicine on the end. And that has morphed into beam lines which are dedicated to treating thousands of people a year around the world. Most importantly probably in Boston, PSI in Billigan, in Paris and in Nice and in Cambridge have got very dedicated, very coordinated beamlines that treat a lot of patients. We obviously don't have one in Australia, and there's a bit of discussion about whether we should develop one or not. The technique is pretty much been established for a long, long time, is very reliable. Again, surgical procedure, the surgeon defines the tumour intraoperatively and puts these little clips, which are typically made of tantalum, onto the orbit, and then they can be visualised on planning x-rays, and then there's a software system that can mark out very accurately where the lesion is and plan the dose. And this wheel just shows you, with a proton beam treatment, it's typically just one beam. So the patient's eye is rotated in whatever direction is felt to be optimal to minimise the distance that the beam needs to travel and to target the lesion and hopefully avoid sensitive anterior eye structures as much as possible. Stereotactic photons is very much a modern practice because until we had decent imaging guidance and stereotactic linacs, we couldn't do this safely, which is why it's only been happening in the 90s, and proton beam was the only external beam modality we had in the past. So it can be done with a gamma knife, although in Australia it's done here in Sydney and by us with a linac. So I'll just talk about what we do because I know that best, obviously. So this is our modern whiz-bang linear accelerator, and if you look up here, this is the aperture where the radiation comes out, and these little guys here called the multi-leaf collimator. On our machine, the smallest ones are just 2.5 millimetres, so that enables us to define a very small field. And the system, the linac, the couch, the mask, the whole system gives us millimetre accuracy. On top of that, we've adopted an idea which came from Vienna, whereby the patients gaze is tracked, because obviously you can have the head very still but the eye could go wherever you like, which isn't very useful when you're trying to target a very small lesion in the eye. So we have a mirror here the patient looks at, and here is a camera with a flashing light, and they look at the light, the camera monitors the position of the eye, and we can just literally just watch that whilst they're having treatment to make sure that their eye is staying still. And it's really remarkable what a machine the eye is, even if it's not seeing very well, how still it can stay. We've adopted proton fractionation, which is classically 5 fractions in 1 week, but they're very radioablative high doses, and I'll talk a little bit more about that in a minute. We take our system, which is MR compatible, into the MR scanner, and so the patient has a planning CT, which is typical in radiation oncology, using the eye tracker. Then we go to the MR and do the same thing, and that enables us to match the anatomy really very, very well. And so we're very, very confident that we can define the tumour very clearly here. We just do a 6-minute T2 sequence without worrying about contrast. It's a bit unpleasant for the patient to be with the eye coil and the mask and everything, so we try to do it as quickly as possible. And we can see the tumour very easily, can see the anatomy. Really, the resolution on the MR is really very high, and it enables us to define our targets. We mark out normal structures like the nerve, the lens. I look at the lacrimal gland location, and the contralateral eye, obviously, and then we can define our little volume here. So this is actually a patient who's on a trial of mine at the moment, has 60 Gray coming to our targeted planning target volume with a fall off to about 45 Gray fairly quickly for the radiation oncology. It's about 2 millimetres, and then this is 1 Gray, so very, very low dose. So the nice thing about radiation, which is why it's been used, is that it allows preservation of the eye. And I've put vision in brackets because I must admit, as a radiation oncologist, I'm a bit disappointed with how many eyes I make blind. And I find it not the most rewarding thing to be treating people. They obviously like to keep their eye, but if it's not a useful eye, perhaps it's a bit disappointing. But the good thing is that we know from this collaborative ocular melanoma study that was conducted some time ago, a 12-year follow-up was published in 2006, that in that study, patients were randomly allocated to either have primary brachytherapy or primary enucleation. Very brave patients to agree to be randomised in that way. And the bottom line was that death from all causes or death from melanoma, be that with a proven biopsy of the metastasis or just an implied biopsy of metastasis, survival was exactly the same. And in the modern era, we've come to understand that that relates to the biology of the tumour rather than the treatment. This trial wasn't designed to be powered for any biologic difference between a class 2 or a class 1 tumour. And as a breast radiation oncologist, I think, well, maybe there's a little group in there that maybe there is a difference depending on local control. But the biology of melanoma is obviously very different. It's very binary behaviour, and perhaps this really does ring true. Nonetheless, people are very comfortable trying to preserve the eye wherever possible. And so if we look at the different kinds of radiation therapy, what are their strengths and weaknesses? Well, the plaque and protons are a little bit invasive. You have to have a procedure to define the location of the tumour. Plaques classically are not particularly good when the disease is right over the optic nerve. You can have a notched plaque, but they still get a bit cold, the dose, and so they tend to progress more readily there. It doesn't matter. I mean, in a very specialised centre, I think, can treat iris and ciliary lesions with plaque and or proton. It's not something to be done by those who don't do it very often. And it's very difficult with any radiation modality to treat a flat lesion. Some lesions can grow in that they almost don't have a thickness, but they're quite broad in their base, and it's very hard to define the beginning and the end to avoid a marginal miss. The acute toxicity of plaque is pretty mild. I thank Willie for telling me you can get this very acute retinal edema, and occasionally the oculomotor muscles don't like to work quite as well as they did before the procedure, although they tend to recover from that. And the cost is what I'd say moderate or even low, depending on how you want to classify the costs. In contrast, protons are also, they're treated, flat lesions are treated, but it's hard to find them. There's a bit of evidence around safe use of iris and ciliary body treatment for iris and ciliary body lesions, but that the anterior tissues get much more dose from proton radiotherapy. So when we give external beam radiation to the back of the eye, we see almost nothing. The patient's eye looks normal. They don't have any acute toxicity, but the acute toxicity from protons, you can get a little bit of a skin reaction and maybe get a bit of a fibrosis or eyelash loss and so forth. And the cost is the main issue. It's very high. And so when we do stereotactic treatment, we really see minimal acute toxicity. And the cost, again, we've got linear accelerators being used for treatment of other cancers. It's hard to measure exactly what a cost is, but if you can adapt your system, it's relatively cheap treatment, I suppose, and as opposed to a proton beam line has to be specifically for the eye. So as a radiation oncologist, I always think about normal structures. We don't want to harm things, and I'm not an ophthalmologist, so I think about the eye fairly simply, not with all those layers and wonderful things in the retina that you know about. So anteriorly, we've got very radiation-sensitive structures. Posteriorly, they're relatively radiation-resistant nerve and vessels, but traditionally in ocular melanoma, the doses that are used are really, really very high. 10 times more than we would use for treating a great big lung cancer or something. And so not surprisingly, we overwhelm the tolerance of those tissues as well, quite commonly with the doses that are used. So the things that we try to avoid, but it can certainly happen with anterior high-dose radiation, and that might occur with trying to treat an anterior lesion or with the proton beam coming through to something very anterior. You can get ulceration of the cornea, which is painful, neovascular glaucoma and a dry eye, or even ultimately leading to rubiosis, needing to take the eye out for pain and symptoms, not for tumour. Cataract, it's just very, very easy to induce a cataract in the lens with very, very low doses, and I've just put that in brackets because fortunately in the 21st century you can replace cataracts, but in many ways it's a small aspect of vision loss compared to these other factors. And at the back of the eye, if you're giving the big blasting doses which are used in protons and typically with fractionated stereotactic, you will inevitably induce toxicity in these structures because the dose tolerance is just completely overwhelmed by the doses that are used. So as I said, vision loss is very common. And the patients that I treat all have tumours sitting here, macular or optic nerve. So they're very unlikely to have good vision outcomes. When a lesion's sitting out here, if you treat them with a plaque or protons, you usually can get much better vision results. So I've just tabulated this from our experience and from the fractionated stereotactic published experience, and you can see acute toxicity, really very little, hardly ever anything really. A bit tired, eyes a bit watery, maybe feels a bit ironically scratchy as well as watery at the same time. That usually settles down within a few weeks. But the sort of toxicities that radiation oncologists don't like seeing, which is significant retinopathy and optic neuritis, are very common, basically because of dose. And all my patients who've got posterior lesions, pretty much they're all blind in that eye within 3 to 5 years of their treatment. So if we look at the doses that are delivered, I'm sorry, I've forgotten to look at time, that's okay. As I said before, plaque is usually about 8 to 85 gray, although it depends how thick the tumour is, whether it's prescribed to the apex or just at 5 millimetre depth. Local control results are good. In the COM study, the local failure was about 85%, but other series have certainly got results around 90%. And toxicity is relatively low for either problem. Protons, as I said, these doses, when they first started in the 60s or 70s, it's very hard to find any rationale for the doses other than we think melanoma is pretty resistant, we don't have a lot of access to the beamline, we better blast it. And so that's what was done. 70 gray in 5 fractions in a week is a massive dose. It's like 150 gray biologically for the oncologists in the room. And some departments have modified that slightly and give 50 or 60 gray in 4 fractions in a week. So the patient comes on day 1 of the week, has all their measurements done, the next day they start their 4 fractions, and it can all be done in a very efficient week. But toxicity is ironically higher enucleation for toxicity is higher than for disease progression, which as an oncologist feels a little bit back to front, and I think exploring dose is something of interest in this disease. And stereotactic results are very similar, the patient populations not being exactly the same. So I just thought I'd pull out a few little studies of interest without wanting to go into too much detail. Damien Webber runs the department at PSI, and they did a planning study, so there weren't any patients involved, but they looked to see whether proton beam or fractionated stereotactic would give you better results. And they tried to have the same target volumes, and they tried to match things up as well as they possibly could. And you probably won't be able to see these very well, but they tried to look at a lesion posteriorly, lesions very anteriorly. And the bottom line is that really the ability to target the tumour safely is very similar for posterior tumours, for protons and stereotactic. You don't gain a huge amount. The very, very low dose, the 1 gray kind of dose, is more widespread with photons because X-rays penetrate things, whereas protons just stop. And then very anterior tumours, as I've alluded to before, it's harder to be non-toxic using photons in that situation, and I would always think plaque or protons would be better in that circumstance. And then this is a study that was actually a clinical study, phase 3 study, comparing helium ions, which is not a very common particle to be used, but was done with iodine. And it's a fairly old study, but with long follow-up. The problem with this study is that the doses were numerically the same, but this is biologically a lot hotter dose than this one. And more particularly, the margins required for plaque were very small compared to the margins required for the charged particle. So you're not really comparing apples with apples, and perhaps not surprisingly, the local control in the iodine group wasn't as good as with the particles, but it's hard to know how much of that was because of marginal miss and poor planning, really. And then the Sheffield group, who are in the UK, who have a gamma knife and also use plaque, have done a similar sort of thing where they've just looked at the outcomes of their patients. It's not a randomised study per se. And because they were using a gamma knife, they just use a single fraction of radiation, 35 gray 1 fraction, which is certainly a blast, to say the least. and they have very good local control, very similar to the proton beam. They tried to demonstrate that the tumours were fairly comparable in nature, and the vision outcomes were a lot better in the proton group. And it did depend, as I've alluded to before, on their location in the eye. It's hard to glean from the paper whether they were really using gamma knife for many tumours that were sitting quite anteriorly. But I think there's enough information to show us that photons or protons or brachytherapy, if you get the right dose in the right place, will achieve high rates of local control in the eye. Now, I'm quite interested in dose of radiotherapy that's used, as you've probably heard as I've been talking through. So the Boston group, quite some time ago, did a randomised study, it was published in 2000, where they randomised patients between 70 gray and 5 fractions, which is 14 gray per fraction versus 15 gray and 5 fractions. And they found there was no difference in tumour control, no difference in overall survival. There was a little bit less optic neuropathy in the lower group, no difference in visual acuity, but the fields were a bit better preserved in the lower dose group. But they persist with using 70 gray, so I'm not really sure why. It hasn't ever been a subsequent publication to say whether they felt they were losing control or what. But it was interesting to me that the dose was reduced by 30% without any change in tumour control. And to me, as an oncologist, that means that we're just well above the dose threshold that we actually need to control these tumours. We could be a lot lower without compromising any of the efficacy, but hopefully we could reduce toxicity. A group in the US have done a similar idea. They just a phase 2 study of only about 60 patients, and they gave 60 gray to the apex of their tumours instead of 80. And again, they found that their results were very comparable with the published literature, but their personal toxicity rates were lower with better vision outcomes. And the Viennese group, who've pioneered fractionated stereotactic radiotherapy, just over the time that they were treating the patients, they started off, they adopted the proton dose. Over a period of time, they were concerned by toxicity, so they systematically just reduced the dose to 50 gray and 5 fractions, and they've had exactly the same control in the eye and distant survival with that dose reduction, and a suggestion that they've got better vision in the lower dose, although they haven't published vision outcomes with longer follow-up for the 50 gray group. But because of their work, the group in Rotterdam and ourselves and other departments that use stereotactic tend to use this lower dose because we don't see any advantage to using the higher dose. So I'm currently running a very small study at Peter Mac, and I'd be keen to discuss it with anybody who's interested, just exploring whether it's possible to do what we normally do in radiation oncology, which is try to avoid harming normal tissues. What we call standard fractionation is a very small dose per day, only 2 per day rather than 10 or 14, which has been used traditionally in choroidal melanoma, because we know that those dose sizes daily protect tissues like nerve tissue and vascular endothelium from injury. Epithelial tissues is not such an issue, but for what we call late reacting, scarring, fibrosing tissues, this is really very important to protect them from injury. But in order to do that and do it in a meaningful way, you basically also have to reduce the biologic dose that's being delivered to the tumour. So it's a kind of two-pronged thing. And the hypothesis is that we might be able to protect the eye from late radiation toxicity and hopefully improve vision outcomes without compromising control of disease in the eye, so the patient gets to keep their eye, but maybe it'll be a bit more useful for them. And these are the criteria that we've got. It's moving. We've actually got about 14 patients on study now, and anecdotally, I don't think we've disproven our hypothesis at this point. We've certainly got at least one patient who's 5 years from treatment who's got no retinopathy at all and has had no change in his vision, and his tumour is just stable. I don't think we're causing the same blast-type scars that we used to get at the back of the eye with the high doses, which is perhaps not surprising, but the tumours seem to be sterile and they're not progressing. So we'll have to watch this space. And just one little extra comment about genotype and radiation response. There's not a lot of literature around this. I think there was concern initially that there might be differences in response and maybe class 2 tumours are harder to treat. It would appear from the limited literature that it's not so much the class, whether they're responding or not, but probably just that class 2 tend to be bigger and nastier, and they're the ones that are harder to control. As these two groups have looked at response rates and found either the same response rates regardless of class at only 3 and 6 months, I'd have to say. And the Texas group, who were instrumental in defining these classes, initially thought they were seeing earlier more response in the class 1 group, but over time they found that there was no difference between the two. So I think that's all I've got to say. Thanks very much. Oh.